So hello everyone to the ERKNet webinar series on Tuesday. My name is Stefanie. I'm project manager at ERKNet and responsible for the education program of ERKNet. And so I welcome you to the new session where we focus on the clinical practice recommendation on kidney management in MMA. And before we start the webinar, I would like to remind you that you cannot ask questions in between, but you can send them to our question box and we will answer them afterwards after the presentation. I would like now to introduce Aude Servais, who was responsible for this clinical guideline project together in a collaboration also with the MetabERN. And she is a senior nephrologist in the Department of Adult Nephrology at Necker Hospital in Paris, France. She's a referent in adult nephrology and metabolic diseases in the Reference Center for Child and Adult Hereditary Renal Diseases and in the Reference Center for Inherited Metabolic Disorders at the Necker Hospital. She was the chair of the ERKNet working group on metabolic stone diseases until the May of this year, 2025. And she has coordinated clinical practice recommendation on kidney management in MMA in 2024. Her research interests include the management of cystinosis in adolescents and adults, genetics of kidney diseases, and in cystinuria. So, Aude, thank you very much for being here and to give us an update on this very new project and recommendation document. Thank you.
Thank you, Stefanie. Good afternoon. We will discuss about the clinical practice recommendation on kidney management in methylmalonic acidemia, which was an expert consensus statement from ERKNet, but also a collaboration with the MetabERN. Methylmalonic acidemias are a group of rare inherited metabolic disease affecting the propionate catabolism. We will today focus on classic isolated MMA. The propionyl CoA, which is the precursor of methylmalonyl CoA, is derived from diverse sources: gut bacteria, amino acid, and hot carbon fatty acids. And this group of MMA is a group of autosomal recessive disorder caused by pathogenic variants in MM-mutase apoenzyme or in genes required for the provision of the cofactor adenosylcobalamin. These cofactors include CBLA, CBLB, and CBLD. So the classification of the disease depends on the genes which is mutated, and we design M-MUT0 with no activity of the enzyme, mutase negative with low activity of the enzyme, and then variants in cobalamin A, B, or D. And altogether, approximately 1/2 to 2/3 of isolated MMA patients have mutase coenzyme defect, and the other patients have cobalamin variants. The common feature of this disease is elevated concentration of methylmalonic acid in blood, urine, but also in other body fluids. It's a very rare disease with overall incidence of 1 in 50,000 newborns. And chronic kidney disease is a common complication of this disease, leading to kidney failure, dialysis, and kidney transplantation. And also, the metabolic treatment of the disease may require dialysis or liver or combined liver kidney transplantation. So our goal was to focus on the specific aspects of kidney management of this metabolic disease. It was work done in collaboration with ERKNet and the MetabERN, and both pediatric and adult nephrologists, metabolic specialists, liver and kidney transplant specialists across Europe were involved. And the recommendation was published last year. If we look at the management of MMA, you may know that the goal is to reduce the production of methylmalonic acidemia in this disease. And how to do this? First, we propose protein restriction around 1 gram per kilo per day in early childhood, and it will be adapted to patient needs. But it's also very important to maintain optimal caloric intake. And then we will propose to the patient oral carnitine, aiming at to prevent carnitine depletion and also to allow propionyl carnitine excretion. Indeed, the propionyl CoA, which is the precursor of methylmalonic CoA, is supposed to be responsible for some of the toxic effect in MMA. And then carnitine will also restore coenzyme A levels and replenish intracellular carnitine stores. Then in the treatment, sometimes in some teams, it is proposed to prescribe some antibiotics to reduce intestinal production of propionate and MMA. And some patients may also receive some amino acid mixtures without the precursor, but this is controversial. And altogether, it's important to avoid prolonged fasting in order to reduce lipolysis. And so in children, nocturnal tube feeding or gastrostomy feeding is sometimes required. And so the circumstance that these patients should avoid is first fasting, but also increased dietary protein. And which are the complications of the disease? First, the patient may have some neurological complication with a variable intellectual disability. They may have some acute episode as metabolic strokes causing movement disorders and some MRI defects. The patient may have some acute or chronic pancreatitis. They may also have some growth failure, which is very frequent. It's multifactorial due to the protein malnutrition, the acidosis, and also chronic renal failure. In some cases, you may have some bone marrow failure due to toxic organic acids, but it will revert to normal after the decompensation. Severe complication is acute visual loss due to optic nerve atrophy, which is a sign of decompensation. And some patients may have fibrosis in the liver, leading to cirrhosis, and some rare cases of hepatoblastoma have been described. And of course, chronic kidney disease. All patients are at risk of chronic kidney disease. If you perform some kidney biopsy, which is not required, but here are some specimens of kidney after nephrectomy, after transplantation in some children. And you may see some fibrosis and interstitial fibrosis and tubular atrophy and moderate inflammation here. And here you have more severe disease with ischemic glomeruli, tubular dilatation, and thickening of the media of the arteries. There is no glomerular disease. It's probably due to some mitochondrial dysfunction and direct toxicity of MMA. If you look at the series of patients with MMA, we know that chronic kidney disease is more frequent in patients with mutase 0 or CBLB deficiency. Here in this French cohort, you can see that a large proportion of patients with mutase 0 of cobalamin B had chronic kidney disease. It was less frequent, or later, it appeared later in patients with mutase negative or cobalamin A deficiency. Altogether, half of the patients developed chronic kidney disease. These were very young patients because the median age at last follow-up was 12. So some patients may develop chronic kidney disease later. And it was early complications the median age of patients with chronic kidney disease was 6.5 years. And you can see that the proportion of patients with severe chronic kidney disease increased with age. Age at chronic kidney disease presentation was also depending on the subgroup of patients. Median age was 8 in MUT0 patients, and it was later 11 or 13 in CBL-A or CBL-B patients. And if we look at the free time period without kidney failure, you can see here that MUT0 patients have worse prognosis compared to negative or cobalamin A patients. The predictive factors of chronic kidney disease are both age at onset of the disease, neonatal versus late onset, and the cobalamin responsiveness. This patient may have some rapid deterioration of kidney function, so a close monitoring is required. And altogether, on 61% of patients MUT0 will develop kidney failure, 66% cobalamin B, and 21% of patients with cobalamin A. And we need also a longer follow-up for these patients to have good numbers. We know that there is a correlation between metabolic control and chronic kidney disease. And in this study, you can see that patients with chronic kidney disease had a higher mean MMR excretion than the others. But how to assess the kidney function in these patients? We performed a study in adult patients, non-transplant MMA patients. So these are adults with a median age of 24. As you may see, the majority of the patients have CBL-A, which is a less severe disease, and probably the MUT0 patients, most of them have already been transplanted at that age, but we also had MUT negative patients. And in this cohort, the median measured GFR by OXL was 56 milliliter per minute. 3 patients had completely normal kidney function, and the majority of these young patients had stage 3A chronic kidney disease or lower kidney function. But what is interesting is to note that the usual formula overestimates GFR in this patient. Indeed, this patient have a decreased muscle mass and low protein diet, so the routine laboratory markers such as creatinine are poorly predictive of kidney dysfunction. And we show here that there is an overestimation of kidney function by CKD-AP of 24 milliliter per minute in this patient, and also an overestimation of Schwartz formula for more than 15 milliliter per minute. So if we want to estimate GFR, we should use cystatin C, for example, in this patient, or to measure GFR if there is an important clinical decision to take, for example, start dialysis or the choice of transplantation. In this disease, the rate of kidney growth is also impaired by 1/3 to 1/2 of normal values. And it was shown that kidney growth is predicted by age, and it's correlated negatively with serum cystatin C and plasma MMA concentration. So we could propose in these children to repeat kidney ultrasound to evaluate the kidney growth. On a metabolic point of view, there are some laboratory parameters that we should follow. The ammoniema, the lactate, the plasma amino acid, MMA in plasma and urines, but in patients with chronic kidney disease, the metabolic follow-up will rely on plasma MMA as the kidney function decrease. And we will also look at the acylcarnitine profile. And then, as in all the patients, the nutritional status should be assessed, the bone health, the kidney function, the pancreas function. It's very important to have some expert dietetic support in this patient to ensure adequate nutritional status. And then when should we start dialysis in these patients? There are, of course, all the usual kidney indication of dialysis, but there are also some metabolic indications. First is acute metabolic decompensation. This is a life-threatening emergency, and the dialysis will help to clear toxic metabolites and correct clinical laboratory parameters. So dialysis should be performed as soon as possible when the initial medical management fails. This means that in case of acute severe neurological symptom, change in level of consciousness in patients, or persistent ketoacidosis, rapidly rising or very high plasma ammonium or lactate level. And then in some patients, we will also have to start dialysis for chronic follow-up and chronic managements. And there again, dialysis will help to clear toxic metabolites. So it should be started when MMA concentration are rising with metabolic and clinical instability despite optimized control protein intake and medications. And it's very important to note that we should not decrease protein intake to control MMA concentration. So if the level is still high despite good control of protein intake, then dialysis should be started. It means that dialysis may be required at higher eGFR levels compared to usual kidney patients. Which dialysis modality should we choose in the acute setting? Continuous veno-venous hemodialysis or intermittent hemodialysis are preferred to peritoneal dialysis to achieve a rapid metabolic control. But if there is some technical difficulty to perform hemodialysis, peritoneal dialysis may be considered until the child is moved to a center with appropriate dialysis facilities. And of course, in adults, we perform always hemodialysis. And for the long-term chronic dialysis, both technique, hemodialysis and peritoneal dialysis, are effective in the long term. Hemodialysis may be more efficient, but peritoneal dialysis is a good option, in particular in infants. And it's important to note that you may have some rebound of MMA in plasma, or you will have some rebound. So it's usually we perform a frequent daily long dialysis to achieve a good MMA clearance. And from a technical point of view, we should use bicarbonate-based dialysis fluid. And then on dialysis, natural protein intake will be increased according to the biochemical profile in order to prevent chronic protein malnutrition. So dialysis is usually considered as a bridge to a transplantation. So why should we transplant these patients? First, we know that despite early diagnosis and increased knowledge, there is still an important morbidity and mortality in this disease. There are some long-term complications. We already discussed it. The patient may have metabolic decompensation and a poor quality of life. So a low protein diet is not a perfect therapy. And if we perform transplantation, in particular a liver transplantation, we will restore some mutase activity. So it's also a kind of enzyme replacement therapy. So which are the indications for transplantation? Liver or combined liver kidney transplantation should be considered in all patients with a severe disease, regardless of the genotype. But we know that severe mid-zero patients have a natural history more severe. We could perform a preventive liver transplantation before the long-term complication in these patients. Another indication is high rate of metabolic decompensation, so a high burden of disease, difficult metabolic control, and so high risk of long-term complication, including chronic kidney disease, neurological deterioration, chronic pancreatitis, or optic neuropathy. And of course, we will recommend transplantation in case of kidney failure. So when should we perform these transplantations? Altogether, there are 2 types of indication. So either a young patient with a poor metabolic control, a frequent hospitalization, so high risk of acute neurological damage, high risk of death, and poor quality of life. And there are also long-term complications, chronic kidney disease, but also the risk of further neurological complications. Now we can also identify young patients in whom the transplantation may be offered early at a pre-symptomatic stage. In this case, we will perform a liver transplantation. We should always perform the transplantation when the patient has achieved some metabolic stability, and it should be performed by a multidisciplinary experienced transplantation team, including a surgeon, anesthesiologist, metabolic specialist, nephrologist, cardiologist, dietitian, psychologist. It's a very high-risk transplantation. And which kind of transplantation should we choose? Either we will choose early liver transplantation in severe MMA patients without renal impairment. The right level is discussed by case, but if GFR is above 45 meters per minute, we usually perform liver-only transplantation. It will allow to prevent long-term complication. In patients with moderate to severe renal impairment, chronic kidney disease stage 3B or more, then we will propose today a combined liver kidney transplantation. In some patients, we may propose isolated kidney transplantation. It is a safe option with less morbidity and mortality than liver or liver kidney transplantation. And this may be proposed in adult patients with cobalabin responsive or CBLB patients. Altogether, this discussion should be individualized. This is a very specific procedure. So before transplantation, a complete cardiac assessment should be performed. Of course, blood pressure measurement, electrocardiogram, echocardiography. In case of any anomaly, MRI, cardiac MRI should be performed. The patient should have some developmental evaluation and brain MRI and ophthalmologic examination. And then the perioperative period is a very difficult period. And in this case, we should prevent catabolism and avoid metabolic decompensation. So as in most of this kind of metabolic disease, fasting will be replaced by 10% glucose and lipids to block lipolysis during the procedure. We will give the patient continuous intravenous ERKNet. We have no data about the potential benefits of perioperative hemodialysis, but in case of chronic kidney disease, we will perform some hemodialysis before surgery, or in case of very high MMA level. But CVVH should be available if necessary, if there are some difficulties in metabolic control during surgery, according to lactate, ammonia, or metabolic acidosis. And from a surgical point of view, which should minimize the times of caval and portal clamping to reduce the risk of metabolic decompensation. And then after the surgery, lactate should be checked, and in case of high lactate level, a dialysis should be performed. We give the patient vitamin B1. The parenteral nutrition may be required immediately after transplantation, and parenteral protein should be introduced as soon as possible, and enteral feeding, of course, as early as possible. We will continue the glucose infusion until the patient may eat, and we'll monitor electrolytes. What are the benefits of this transplantation? Of course, it will correct kidney dysfunction if the patient has some chronic kidney disease, but it will also reduce MMA concentration and here you can see the result after liver kidney transplantation of the MMA level, which in this French series was very high and decreased after the procedure. It will help to prevent metabolic decompensation, pancreatitis, and it will decrease the hospitalization rates. It may help to improve growth, in particular in a young patient who will get a liver transplantation. And usually cognitive function is stable, or sometimes it may be improved. How we should we adapt the treatment after transplantation? The carnitine will be continue because there are some extrahepatic production of propionyl-CoA, which is toxic. And the diet composition after transplantation is debated. But in our experience, the patient can tolerate a natural protein intake according to age requirements. And you can see here again in the French cohort, here is a patient who received only kidney transplantation, and you can see that protein increase was not very high. But if the patient received liver kidney transplantation or liver only, you can see that after transplantation, the protein intake per day was really increased. The patient have less frequently nausea after transplantation, and so if they were on enteral nutrition, we will be able to withdraw this, and almost all patients are fed by mouth within the 12 months after transplantation. If we look at renal outcome, of course, if you have a kidney transplantation, you will improve kidney function, we hope so. But in the long term, the kidney failure may recur, and probably a little bit faster than in other disease. We saw some patients with accelerated fibrosis. After liver transplantation, the renal disease will continue to progress. Here are some results in the short term, so the kidney function is rather stable in the short term. But in the long term, the renal disease will progress. And of course, after combined liver kidney transplantation, the patient had a lower kidney function as this procedure was chosen, and then they improved their kidney function. There are some post-transplant neurological deterioration in these patients. This may be due to MMA toxicity, a kind of cerebral MMA toxicity, but we have also observed, and it has been published in several series, that there is a toxicity of immunosuppressive medication, in particular calcineurin inhibitors. And this may be detected in patients with new neurological symptoms during the first weeks or months after transplantation. We have some data in the literature of around 32 patients with neurological follow-up, and almost half of them had no neurological toxicity, but 1/3 of them had some neurological complication due to immunosuppressive toxicity, either abnormal movement, myoclonus seizures, or Press syndrome. And 22% of these patients had kind of metabolic stroke. So there again, some neurological complication, but not due to the treatment. In these cases, tacrolimus levels were in the normal non-toxic range. So it's important to analyze the timing after transplantation. The calcineurin inhibitor-induced neurological symptoms will appear a few days or months after transplantation. If it's occur later, it's maybe more metabolically induced. We should measure, in this case, MMA in CSF, and in any case, we should reduce or stop calcineurin inhibitors and modify immunosuppressor. And in particular, in adults, we will propose sirolimus. And after some time, the patient will recover and there is a good outcome. The pathophysiology is not clear. Probably there is some impairment of oxidative phosphorylation by CNA with a pre-existing mitochondrial dysfunction in these patients. So that's why we recommended to choose a specific immunosuppressive regimen in this patient. It will be chosen based on age, adult and pediatric, and type of transplants. We will use the induction agent as per local protocols. It will include calcineurin inhibitors and mycophenolate mofetil or steroids. But tacrolimus is particularly poorly tolerated in this patient. So we should propose a very careful clinical, biochemical, and neurological assessment in this patient, and to reduce or discontinue tacrolimus and in a situation with a supposed CNI-induced neurotoxicity. So we have now an increasing evidence that cyclosporine has a more favorable tolerance profile than tacrolimus. We propose to have a very close pharmacokinetic monitoring and be aware that the neurotoxicity is not dependent on plasma levels. We propose a very strict control of all the parameters which could measure the neurotoxicity, triglycerides, cholesterol, electrolytes. And for maintenance therapy, we propose to use mTOR inhibitors in adults in particular. And in our center, we don't use tacrolimus anymore in these patients. What about the benefit on quality of life? There is no real publication focused on a questionnaire, but altogether there is a possible improvement of quality of life because of the reduction of metabolic decompensation and hospitalization. Of course, we can stop dialysis in some patients. We will increase protein intake, stop enteral nutrition. The patient have more energy, they are less tired, and there is an improvement in weight and age. And there are some data on quality of life for the patient after liver transplantation. We should follow this patient with metabolic specialist and dietitian. It's very important to have a multidisciplinary team, including a pathologist, nephrologist, surgeon, and to monitor also the biochemical data, the metabolic biomarkers. We already discussed to monitor lactate, plasma MMA, ammonemia. It's important to have a regular dietetic monitoring and also, of course, kidney function and neurological monitoring. So altogether, the metabolic treatment of this very specific disease may require dialysis. So these are another indication that kidney indication in case of acute metabolic decompensation, which is really an emergency, and also in the long term to clear toxic metabolites. The indication of transplantation are high rate of metabolic decompensation, high burden of disease, difficult metabolic control, so high risk of long-term complications. Of course, it's indicated in case of complication, in particular chronic kidney disease or neurological complication. Altogether, the combined liver kidney transplantation should be preferred in all patients with chronic kidney disease. And due to this neurotoxicity, we suggest using immunosuppressive regimen without tacrolimus in these patients. And after transplantation, a multidisciplinary follow-up should be also proposed to the patients. I thank all the collaborators with whom we work on these recommendations. And I have to state you also that we have a next webinar next week, or no, in 2 weeks, about anti-factor H and auto antibodies. And I'm happy to answer your questions.
Thank you, Aude, for this nice overview. Can you hear me?
Yes.
Super, great. So thank you very much. So for our attendees, this is a little reminder that you are you should ask questions to Aude if you have like still some open questions. Just use the question box for this. And in the meantime, maybe Aude, you can tell me which patients could benefit of only kidney transplantation.
Yeah, we mainly focused on liver for early transplantation or liver kidney transplantation. There are some few indications of kidney transplantation for this patient. Initially, we proposed some kidney transplantation also as a metabolic treatment for this patient to restore some enzyme activity, but as you have seen, the results were not so good. So it's not a very good metabolic treatment. So we keep this indication in some fragile patient or other patient with cobalamin A deficiency, or some patients are vitamin responsive, so with less severe disease.
Mm-hmm. Thank you. There's a question from Teresa Papalia. If tests need to be done for neurological evaluation after transplant, and what is the timeline?
There is no specific test. It's important to have a good MRI and good neurological assessment before, so in order to be able to compare. And then it's really first a clinical evaluation of the patients. If there is any clinical neurological defect, we should perform MRI, and then some fluid analysis and a complete analysis. And in this case, first, we usually stop calcineurin inhibitors and replace it by another treatment, unless there is a very strong idea that it's due of a metabolic cause rather than an immunosuppressive treatment cause.
Okay, thank you. Then Bert Bammens asks, to which level of anion gap do you dialyze patients immediately before combined liver kidney transplantation?
So the level before the transplantation, that's for dialysis?
The level of anion gap immediately before combined liver kidney transplantation. So
we didn't want to give you some level because you know, it's always a case by case. So it's really on lactate that we focus on lactate and on rising lactate level for dialysis, and also of course on MMA when the MMA level is higher than 1000. Of course, we propose to perform a dialysis before transplantation.
Okay. And Samantha Innocenti asks, which threshold of plasma MMA do you consider for starting hemodialysis?
There again, we had some discussion because it's there again a question of chronicity of the level, but we believe that above 1000, the patients are in risk of acute decompensation. So if it's not possible to reduce the protein intake because it's already too low, so in order to avoid any further denutrition, we will start dialysis and of course start a transplantation program for these patients. But then it depends on the nutritional status of the patient and also the tolerance. But if MMA is very high, then the patient is at risk of decompensation.
Mm-hmm. Thank you. And Martin Conrad raised a question. So did you observe infectious complications more frequently, for example, because of bone marrow suppression?
No, not really. We have no experience of more infection or more rejection in these patients. But we observed some patient with fibrosis, and we thought that maybe it's also due to a difficult tolerance of calcineurin inhibitors, so as if the patient has an accelerated fibrosis due to this treatment, but no immune defect in these patients.
Okay. And then we have another question from Lucas Bergerhausen. So do you have a cutoff GFR at which plasma MMA should be used instead of urine MMA in order to measure metabolic control?
Plasma MMA is always useful. In our department, we also use urine MMA, but probably below 45 meters per minute. We should focus more on plasma MMA. And altogether, in any patient with chronic kidney disease, as the urine expression is less reliable, we should most focus on plasma MMA.
Very good. And I think you answered all of the questions already. So I think most of the people were already happy with your explanations. So thank you very much. If there's no other question coming now, then I think we can also end the webinar a little bit earlier today. And for everyone else, you can also still see the webinars on our YouTube channel, which it's called ERKNet. So here you can find all other webinars also to rewatch. So then thank you again, Aude, for the nice webinar, and yeah, have a nice afternoon, everyone.
Thank you very much.